Everyone, and thank you for attending our ID series today. We are delighted to have one of ours, Kimberly Williams, who is a research investigator in the Value Institute, giving us a talk about practice-based research networks, a clearly very important topic for community research and also for our ACCEL CTR. But before I introduce her, let me mention some housekeeping issues. We will continue to extend CME credits for our Tech Talks and ID series. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Lisa Maturo. And I'll leave her email, I'll write her email in the chat of the Blue Jeans screen. Our April 16th ID series is Dr. Yandelela Kofe from University of Delaware, and she will talk about community-based approaches for promoting healthy behaviors among African Americans with hypertension. So please do not miss that one too. This will going to be extremely interesting. And we don't have yet a Tech Talk for May 6, but we are working on it. So thank you again. And Kim is a research investigator in the Value Institute at Christiana. She obtained an MPH from the Dornsife School of Public Health at Drexel University in Philadelphia, and is also currently pursuing a doctorate of public health in health management and policy, also at the Dornsife School of Public Health at Drexel University. She was inducted in the Delta Omega Honorary Society in Public Health and in 2020 received the APHA Students Poster Competition Award. She is a member of the Delaware Addiction Action Committee focusing on access to treatment, and her work centers on identifying ways to better integrate behavioral health services throughout the healthcare system. Her research focuses on reducing barriers and increasing access to treatment for opioid use disorder in the primary care setting. Something really important here at Christiana Care. So thank you again, Kim, and we are delighted to hear your talk.
Thank you so much, Claudine. Lisa, I did have a quick question before I begin. I'm going to refer to some hyperlinks in my slides. I wanted those to be able to be shared. What's the best way to share my slides with participants if they're interested? Should I just have people email me directly? I'm happy to do that.
Yeah, they can either email you directly, or if you would like, Kim, you can always pass them along to me, and when I send out the CME credits, I can include them in the email.
Okay, so thank you, everyone, for joining us. In my slides, I have my email address at the end of those slides, so feel free to write that down. You can reach out to Lisa Maturo directly as well for a copy of my slides, so you have a few different options. And Claudine just put Lisa's email in the chat. And Lisa or Claudine, would you mind putting my email in the chat as well, just so people want it ahead of time? But without further ado, I will get started. And if you mind, Lisa or Claudine, would you let me know, can you see my slides okay?
Yes, you're good to go.
Great. Thank you, everyone. It's a pleasure to be here to talk with you all today about practice-based research networks, which I foresee as a potential catalyst for furthering clinical and translational research in Delaware. Before I begin, I just want to note I have no relevant financial disclosures or conflicts of interest to report. And wanted to give everyone just a brief overview of what the sections I'll be going through today. So first, for those who might not be familiar with practice-based research networks, and to avoid leaving people in suspense, I will first define what PBRNs are. I'll then go into some of the background and history of the development of this model. I'll provide some example PBRN projects to give you some additional context of some of the work that's been done to date, as well as some other network programs that might come to mind when you think of PBRNs and distinguish them from the PBRN model, but also talk about some of their similarities. I'll talk about best practices for those interested in developing a new PBRN, as well as the future of PBRNs for the state of Delaware. And finally, with some more context, some example PBRN research questions that kind of just to give you a sense of some types of questions that could be asked for new PBRNs. First, what are practice-based research networks? I think the definition provided by the Agency for Healthcare Research and Quality, AHRQ, provided one of the more comprehensive definitions. They start by stating that PBRNs are a group of ambulatory practices devoted principally to the primary care of patients and affiliated in their mission to investigate questions related to the community-based practice and to improve the quality of primary care. So kind of right off the bat, it sets the stage and the framing for PBRNs really focusing on the ambulatory care space specifically, including primary care, and really that this work is focused in the community, in community-based practices, and again, with that idea of the ambulatory care setting. The definition goes on to include a sense of ongoing commitment to network activities and an organizational structure that transcends a single research project. So I'll talk about this a few times. I think one of the key components of a successful PBRN is a really robust infrastructure that can sustain and support multiple research projects. And that PBRNs often link practicing clinicians with investigators experienced in clinical and health services research while enhancing the research skills of network members. And so this really is another principal component of PBRNs, that you're linking practice-based clinicians doing practicing primary care, seeing patients every day, seeing opportunities to improve that care, or seeing issues and not even sure how to begin to break down those issues and improve the care, and to partner with investigators who are experienced in research but maybe not necessarily on the front lines of clinical care. So this symbiotic bidirectional partnership of working together to improve the care of patients in the communities. And then as these practicing clinicians, I'll go and talk about this some more in later slides, are really involved in the full process, the full research process. In doing so, can enhance their own research skills and experience. So a helpful article by Nutting and colleagues in 1999 identified some key characteristics that PBRNs can really embody and how they can contribute the findings of their work. So first, they examine the healthcare needs that reflect patient populations in their communities. Again, you're linking practice-based networks throughout the community, ideally a broad spectrum of practices. So you're really representing the community by having a number of practices that are networked together and working together on a single research question. PBRNs ensure access to the clinical practice experience and healthcare services provided by full-time primary care providers. So again, this idea that working with primary care providers who are seeing patients every day, seeing issues that their patients face in terms of trying to maintain their health and wellness, and having that full practice experience of and not just kind of anecdotal experience of what they maybe read about, but the kind of that firsthand real world experience of clinicians. In addition, practice-based research networks address practice-relevant questions, and this is a really essential point as well. While they'll apply rigorous and diverse study designs, including mixed methods where you're combining qualitative and quantitative methods potentially, key characteristic of effective PBRN is that they ensure that the research methods do not define the research question. And really, as a researcher, and other researchers would probably agree with me, that any good research study begins with the right question, and everything follows from that. And it is no different in a PBRN. They need to identify the research question that's relevant to the practices involved in the network, and that the methods should then follow from that question, not the other way around. So you shouldn't, I think the idea is that you're not necessarily just looking to tweak your question so that you can ensure that you're, doing a gold standard randomized control trial. The methods might not be best appropriate depending on the question, so it might be something like an observational study instead, a quasi-experimental study. But it all starts with that practice-relevant research question. And finally, PBRNs aim to systematically involve the network providers in, again, as I noted, in the entire process of the research. So defining the research questions, developing the study design, interpreting the results, and reporting the findings. So that entire continuum of research, the researchers themselves are partnering with the providers every step of the way. So now I'll talk about some of the history of the PBRN model and how it was developed. The impetus for PBRNs originated in the 60s. There was an identified discordance between the focus and funding for healthcare research versus where the majority of people actually received their healthcare. And it was noted that the majority of NIH research funding primarily went to tertiary care centers and academic hospitals, whereas the majority of healthcare services are provided in ambulatory care settings and community hospitals. So this really kind of spurred this recognition that more pragmatic real-world research was necessary in the ambulatory care setting as the medical field evolved to try to meet this need. In addition, this kind of propelled this focus of how to better translate research findings into clinical practice. And in a seminal 2007 paper by Westphal and colleagues on the Blue Highways on the NIH roadmap, they identified how practice-based research really is kind of this essential component of being able to translate these findings into practice. Furthermore, they kind of highlighted this how dissemination and implementation research methods can be a key component to translating evidence-based findings into practice. So they really kind of called out how these methods can play a role in that process. And while not everyone might have some exposure to dissemination and implementation research, I do find that sometimes there's some confusion about what these methods entail. So just a brief digression about dissemination implementation research. It's not just implementing or evaluating the implementation of any program or policy. Specifically, what it really is a systematic study of evidence-based interventions and how they're effectively translated and utilized within the context of real-world settings. So it all starts with that identified evidence-based intervention or practice, and then utilizing implementation strategies to effectively translate it into a real-world setting, taking that local context into consideration. So back to the creation of PBRNs. The first PBRNs in the US were two regional networks created in the 70s. The first was the co-op program in New England, which is still in practice today under Dartmouth University. The other was the Family Medicine Information System in Colorado. And these both really demonstrated feasibility and essential proof of concept for that the PBRN model can work in the United States. In the 70s as well, the North American Primary Care Research Group, or NAPCRG, was founded as a bi-national interdisciplinary organization that's dedicated to producing and disseminating evidence-based knowledge for primary care. And I'll talk about some of the work on a later slide about NAPCRG, but I wanted to point them out here because they do hold an annual conference on practice-based research networks. Since 2012, they've been doing this with support from ARC, and they have an upcoming virtual conference in June, and I provided a hyperlink if anyone was interested in learning more about that upcoming conference. So again, if anyone's interested in these slides, I'd be happy to provide them. Later in 1999, ARC was designated by Congress to serve as a principal source of funding for primary care research. So this really spurred ARC to serve as the principal supporter of developing PBRNs and their infrastructure across the U.S. As such, they funded 5 grant programs between 2000 and 2012 to develop PBRNs and their capacity across the country. And again, I provided some hyperlinks to some resources. So ARC has an existing resource center, PBRN registry, they develop peer learning groups, and they have a repository of research tools and resources for PBRNs. So these hyperlinks can lead to those resources for more information for those who are interested. PBRNs can also register with the PBRN Resource Center, and they have 3 membership levels. The first is established, which would require a PBRN to have a minimum of 5 participating practice locations and 15 clinicians. I think this goes to the idea that an effective PBRN really has multiple networks, really represents the community, and by doing so, they have multiple sites throughout the community kind of to effectively represent the population. They'd also have a minimum of 50% of participating clinicians working in primary care, again with that focus on primary care research and delivery. They would have to have an identified PBRN director, and I'll talk more about this in a later slide in terms of what this means for the infrastructure of a PBRN, as well as an established mission statement. The second membership level is developing, and these might be for networks that don't yet meet that established membership criteria, but are working towards that goal. And finally, affiliate membership levels for non-primary care focused PBRNs, which do exist. This is just a map from the ARC PBRN website from their 2019, representing 2019, sites that have been registered. Again, as affiliate, developing, and established membership levels. Just kind of wanted to visually show the diversity across the country of where these sites are represented. And as of August 2020, ARC did note that 185 PBRNs were registered with their resource center, and that this did represent practices from all 50 states and at this point over 25 countries. So in thinking about developing a new PBRN, there are some best practices to consider. And NAPCRE created this report in 2014 that really highlighted what these best practices are, and it's a really helpful, I think the report can be a really helpful resource for new PBRNs in development. They provide not only recommendations and best practices, but templates and examples that could be utilized. So specifically, they provided recommendations for the importance of building a robust PBRN infrastructure, and really that has an infrastructure that can sustain the overall PBRN that's not just specifically focused on any individual study, but multiple studies, and kind of really with a central mission that can guide all of the following studies and work that follow. They provided also recommendations for then the actual individual study development and implementation. So while PBRNs ideally are often comprised of geographically diverse practices, this can present some challenges. So they provided some best practices and recommendations for how to really maintain communication and connections between practices and the primary PBRN center. Also, they talk about the need to educate and train practice staff and clinicians about research. So, practice staff and clinicians in the local practice sites might not necessarily have experience or training in research. So, providing that training is really essential, not only to ensure that the research is conducted in an ethical manner, but it's conducted consistently across all practices. And that then goes to recommendations towards data management to ensure reliability and validity of the research output. And finally, I really appreciated seeing this in the report. They had a whole recommendation section on dissemination policies, which sometimes this component of the research process is somewhat overlooked. And they really talked about, not only the importance of publications and including the, entire network in the publication process or presenting at scientific conferences, but also other ways to promote the work and really promoting completed research studies and sharing best practices with the research network, with the providers, with patient participants, and then the broader community. So this goes to not only showing the success and lessons learned from these research networks, but then ultimately towards changing clinical practice where they identify opportunities and solutions, and ideally changing policy where necessary. So I do have a hyperlink to this report right here. So then taking a step back again to think about the importance of a really robust PBRN infrastructure, another paper identified core elements that the PBRN should maintain. So again, they start with this focus that the PBRN structure should be independent of any single study. And so what this really means is having some sort of funding source that can sustain the overall work and administration of the PBRN that's independent of any single study source. So while there might be grant funding for individual studies, you have some more sustainable long-term funding for the PBRN itself. Noted that there should be a minimum, ideally, of 15 ambulatory practices or clinicians, and it can be helpful to have a roster and list of practices to kind of maintain communication with them and track maybe changes if you have practices join or leave the network. Again, a formal statement of the PBRN's overall purpose and mission can be really important to have kind of some sort of guiding principles to tie together all the work that's being done. So this can be in the form of a mission and vision statement and even a strategic plan, ideally, maybe like a 3 to 5 year strategic plan. And then you'd want leadership who are dedicated to overseeing the administrative, financial, and strategic planning of the PBRN itself. So again, as ARC requires, you have some sort of identified PBRN director or research director. They also noted having at least one support staff member that's dedicated to the PBRN itself, the overall PBRN. I think many of us would probably agree that one staff member might not be enough, especially if you have 15 practices and/or clinicians. But this could be represented by having dedicated PBRN coordinators, a deputy director, and research assistants. And then having a mechanism in place to solicit input and feedback from your network clinicians and their surrounding communities. So this could be, having some sort of board member structure, an advisory council, and even a patient advisory board, again, really to solicit and seek feedback from the community itself. And it's important to think about having two-way communication with providers. So not just disseminating information to them or requesting information from them, but having opportunities to share lessons learned, share our concerns or barriers that maybe individual practices are facing. So having annual meetings, an email or a newsletter, and even practice site visits, which to this day might be virtual site visits, but visits and communication nonetheless. And then lastly, having some sort of research and quality improvement infrastructure is obviously essential. And this can be where partnering with academic institutions and or researchers in other capacities, such as iReach Center at Christiana Care, can provide access to institutional review board, statisticians, and data managers. So to give you some additional context, I thought I'd provide some sample research projects. First, one of the earliest projects was from the Ambulatory Sentinel Practice Network, which was one of the first national PBRNs. And throughout the 80s, they conducted multiple studies that ultimately changed a lot of primary care practices and repudiated some previous clinical guidelines. For example, they identified some unnecessary and invasive at times procedures for new onset headaches and miscarriages for patients. And so this kind of really set the stage for how PBRNs can have an impact on primary care practice. Pediatric PitNet created a virtual parent panel which served as an advisory committee so they could receive stakeholder input on child health research topics, and they utilized this panel also to recruit parents to review future study protocols. Wanted to go back and just point out, so I think what I thought was kind of a key element to this study was that they got advisory input from the parent participants as well, and that they were able to do it virtually, which I think is an essential and key element in this day and age. Next, there was a joint project between two PBRNs, Acorn and Snowcap, and they assessed the prevalence of loneliness in adult primary care patients, and that they identified there was an association between higher loneliness scores and those living in zip codes with higher social deprivation index scores. And I think this was a prime example of how PBRNs can work together to address health equity issues. The Ocean PBRN collaborated with the Bridge C2 Center that helped fund their work to investigate their community health centers, which serve as their PBRN network, and evaluate how they responded to the COVID-19 pandemic in terms of practice changes. And what was really kind of, I think, important to note about this work was that they were able to really quickly mobilize their existing infrastructure to start PBRN data surveillance on these practice changes. And so by March 2020, they identified that telemedicine visits increased by 2,000%, while in-person visits decreased by 80%. While those numbers might not be surprising, I think, again, the key element here is that they had this existing infrastructure so that they could respond quickly to a rapidly changing event in our society and monitor what was happening in their local practices. Finally, we have the Pediatric Research in Office Settings, or PROS, which is the national PBRN network of the American Academy of Pediatrics. They collaborated on a study to reduce inappropriate antibiotic prescribing for pediatric acute respiratory tract infections, or ARTIs. And they were able to reduce the overall rate of antibiotic prescribing by 7% across 19 practices. And I think this demonstrates, the fact that as a national network to have 19 practices collaborate on a single study in a coordinated effort to reduce inappropriate antibiotic prescribing, shows that having this network in place can really have a dramatic impact on many communities. So some other network programs that might come to mind if you're thinking of PBRN and wondering how they might be similar or different. One that came to mind to me was the Clinical Trials Network, or CTN. For those who aren't familiar, CTN is a research network that connects the National Institute of Drug Abuse, academic researchers, and community-based providers. So as a network that's founded by NIDA, they do focus specifically on substance use disorders. And unlike PBRNs, they work across various health settings, not just ambulatory care. However, I have a citation at the bottom of this slide that does provide an example of how clinical trial network sites partnered with PBRN on a combined study to improve care for people with substance use disorder. So I think there are opportunities for these types of networks to partner together. In addition, there's a project extension for community healthcare outcomes, or Project ECHO. Project ECHO utilizes telemonitoring and treatment protocols to educate, train, and support community providers on how to deliver best practice care for patients, often with chronic and complex health conditions. So what's really special about ECHO is that, they utilize this hub and spoke model where you have medical specialists in the hubs and connect them with primary care providers in rural or other hard-to-reach areas in these community health centers at the spokes. And so by connecting with these specialists, they have this opportunity to help get support and training on maybe some complex health conditions these community providers might not see on a day-to-day basis, or might not necessarily have know the best practices. So just having that additional resource and network can be really beneficial. And while this is not a direct framework for conducting research, there's also been examples, as I noted in the citation below on this slide, of PBRNs collaborating with Project ECHO program on improving care. This specifically was with Oregon rural-based practices. So I think these two other networks, I think whether they're a research network or not, they often share many of the same goals and can partner together to improve care. So what does this mean for Delaware? I think that Delaware has a number of resources at the ready that can serve to help develop new PBRNs in the state. First, there's a thriving provider community in ambulatory care. Christiana Care, Nemours, numerous other health systems, as well as private practices in the community, and a number of federally qualified health centers. We also have a number of Delaware Medicare and Medicaid accountable care organizations being developed or already developed, and I think PBRNs could partner with these ACOs in a shared goal to meet these healthcare quality benchmarks and improve health outcomes for both Medicare and Medicaid beneficiaries. Finally, we have the Delaware CTR, which is sponsoring this talk today. And I think what is so exciting about this idea of the CTR could really take the forefront in developing PBRNs in the state. We have an existing network of trained clinical researchers and providers with our many partner institutions, including the University of Delaware, Christiana Care, Delaware State University, Nemours, as well as Medical University of South Carolina. So I think we have a network already in place that could mobilize to start thinking about what a PBRN would look like, what types of sites would be represented, and what kind of overall mission and vision could it pursue. In addition, in the CTR, we have the Community Engagement and Outreach Corps, which is a leader in supporting community engaged research for CTR member institutions, as well as organizations in the community throughout the state. And they really work hard to facilitate research that really meets the needs of the community, and have a number of resources, I think, that could be essential to developing a PBRN. I think including like their Community Advisory Council that has representatives from the community that could speak to what needs should be addressed by a PBRN. I was thinking through what kind of questions could be asked by a PBRN, and obviously a central component of a PBRN is that you have these stakeholders that come together and partner to think about what's the overall mission and what are the research questions that should be asked, what needs to be improved. And so that's an essential process to actually developing the questions. But I thought to give you some examples, just the additional context, I was trying to think through what potential questions could look like in a Delaware PBRN. So obviously in the world of telehealth, this is prime with the pandemic, and I don't foresee telehealth going away anytime soon. I think what happened was it just became to the forefront a lot more quickly and a lot more prevalent than it would have otherwise. But some example questions could maybe be, what are the longitudinal trends in primary care telehealth utilization following the COVID-19 pandemic outbreak in Delaware? So while I think there's a lot of monitoring going on of what those utilization trends were immediately following the pandemic outbreak in Delaware, what do these trends of utilization for primary care look like a year from now, or even 5 years from now? And again, this idea of having a data monitoring infrastructure set up to be able to provide this longitudinal evaluation could be really beneficial to monitor and and maybe, change practice as needed. Another question might be, can utilization of telehealth services through PBRN primary care clinics reduce avoidable ED visits and hospital admissions among rural residents in southern Delaware? So for those who aren't familiar with the state of Delaware, a lot of our southern region has rural and other hard to reach communities, and telehealth could really be a really helpful way to increase access to primary care services. And so this could be a question to see, how could a network, a PBRN network of these primary care clinics utilize telehealth and reduce avoidable and unnecessary hospital utilization and ultimately improve care of these patients in hard to reach areas. Another key area that's of importance to many people and really is, I think, a prime subject in terms of really improving the health and wellness of all patients and communities is health inequities. And so one question I was thinking of was, can training primary care providers on implicit bias improve both the patient and provider experience during primary care visits? And I think what is special about PBRN is that you do have this, ideally, this robust infrastructure and this network of bidirectional communication between providers and researchers. And I think in doing so, an essential element should be building this sense of trust and shared commitment. And so addressing a hard question like this, such as implicit bias, could be better facilitated if you have this established trust between providers and researchers, as well as the patients. And so you can ask these hard questions and really kind of understand that this partnership is for the long haul, and it's not could be an example of researchers, going into community, doing their research, and then leaving, but that this is, a long-term effort to work together to improve care. To that end, another question could be, with the spirit of kind of shared commitment and trust, is how do experiences of discrimination and racism impact patient utilization of primary care preventive services? So again, just thinking about how PBRN infrastructure, this long-term commitment, this shared mission and vision, this robust communication, if you can build this trust and ask these hard questions that really solve these complex problems of inequities for health and healthcare. Another area is behavioral health. And when I think of behavioral health, again, I'm thinking in terms of the context of PBRNs and integrating behavioral health into primary care. And this has been a really important movement for several decades now. But while we have evidence-based models on how to do this well, it's still much easier said. It's easier in theory than it is in practice. So this is where a prime example of where implementation research can be a key conduit of translating this known evidence, these evidence-based models of behavioral health integration into primary care practices. So one question could be, what implementation research strategies improve provider fidelity to an integrated behavioral health model in a PBRN of Delaware federally qualified health centers? So again, these are just abstract examples that I kind of came up with to kind of provide some context of types of questions that could potentially be asked. But again, these would obviously need to defer to a shared stakeholder input and conversation and discussion about what the practitioners in these primary care clinics and their patients see as the primary goals that should be addressed for healthcare. In conclusion, PBRNs can really play a pivotal role in the continuum of clinical and translational research by conducting pragmatic clinical research to determine the effectiveness of innovative solutions in real-world ambulatory care settings. In doing so, they can then better translate evidence-based findings into clinical practice, and this can be done by using dissemination implementation research methods. And ultimately, then the goal can be to change practices and policies to improve population health within the community. Thank you.
Thank you so much, Kim, for this very, very informative presentation. Any question for Kim?
Yeah, I tried to keep my slides short intentionally. I was hoping that we could have a lot of conversations. I'm happy to skip back to any slides if anyone had any specific
Well, I have a
questions.
question, but I'd like to see if anyone else has questions before I start.
I'll stop sharing for now.
This is Chrissy. I had a question.
Sure, Chrissy, go ahead.
Does Nemours already have one of these? Because I think they have a program. I know they called it for short ECHO. Is it one of these programs already at Nemours?
So it could be what I referred to as so the ECHO program has many networks around the country. It originated in New Mexico, but they could have an ECHO hub and spoke program, which may not necessarily be a research program, but that could be an opportunity for a newly developed PBRN to partner with the ECHO program.
Kim, I could answer that. Chrissy, the ECHO that you're talking about is a different type of ECHO. That's a NIH study of a children's research study. It's not the ECHO, meaning the peer learning network ECHO that comes out of New Mexico. So it's a different program.
Okay, thank you.
So I'm wondering, Kim, what would be a sustainable model? Because obviously, if there is NIH funding from one study, it could be applicable, but it's not sustainable. No. So I don't know what is the funding of the other PBRNs networks. What can be done? I'm kind of at loss here.
That is a great question, and that's not something, I'll be honest, it's not something I explored in terms of determining how the current PBRNs are funded. I know that some have received program funding from ARC, so it wouldn't be like research funding for an individual study, but you still could get federal grant funding, but it's programmatic funding. I think other PBRNs, a lot do partner with academic institutions. So like the co-op program, really it's in New England, in Maine, Connecticut, New Hampshire, and Vermont, and it's led through the Dartmouth University. So I think they have funding through Dartmouth University as well to support the PBRN infrastructure and not just individual studies. That is something that's a great point. I was hoping, I am developing kind of an internal report with a lot more details about PBRNs. And so that is something I will add to the report. I was hoping to get some additional feedback today so I could, for other details to include. Does that answer your question?
Yes.
It is an excellent question. I think the idea is, you're not seeking, there's study funding, whether it's from a foundation or from a federal organization, and then there is programmatic funding. And I think that is the distinction, is that we're really looking towards programmatic funding for the PBRN itself.
The infrastructure seems extensive, and
yes.
That's where you really need funding.
Yes.
Because you cannot, you need to have coordinators, assistants, research coordinators.
Mm-hmm. To me, I see that's, I hammered that point through several times, but I think that really can make or break the success of a PBRN is having that robust infrastructure that could support and sustain work over the long haul, not just any individual study, but multiple studies, and studies over time. Yes.
Hi, my name is Mort Wasserman. I used to direct one of the PBRNs you mentioned. And the tension between, you were right to point out infrastructure funding as a critical element. Project-specific funding, however, is what gets projects actually done. And the real tension between a community-based effort and project-specific funding is that the money is in the federal government for research projects, foundations to some extent, but NIH mainly. NIH is a disease-oriented, organ-based entity. And so their review panels are more interested in disease. ARC is very interested in primary care, but is a very poor source of funding for individual projects for a variety of reasons. So that's the real tension. I'm very excited to see that Delaware starting something like this. I think it's a great opportunity, but many of the projects you mentioned would require some significant funding. And then, of course, NIH wonders why they should be funded in Delaware and not somewhere else. So anyway, there's just an active tension there, that's all. But by the way, an excellent presentation, because I was present at some of the historical elements you mentioned, and it was fun to hear them recounted perfectly, actually.
Oh, thank you. Yeah, I hope I did it justice. I was really impressed by the history of the PBRN development, and in reading articles about it, really what I saw that came through is that dedication to this model and seeing this model succeed, and that ultimate mission behind of improving primary care, changing clinical practice, and improving health of communities. And yeah, not in just this disease-centric focused model, but really improving wellness of people and truly what we now define health as. Thank you.
You're welcome.
One note also, Dr. Wasserman, I wasn't sure if your experience was similar, but I do know that some PBRNs work have been developed through the CTSA structure. I don't know if other CTRs have developed PBRNs, but I do think for Delaware that could be a key resource, as I noted, for the development of PBRNs could be through our Delaware CTR network.
I agree. I think you have an infrastructure in terms of academic kinds of support, whether it's IRBs and or researchers, actually, obviously. Mm-hmm. And you also have health systems. One thing that you didn't mention that I think is important for 21st century PBRNs is linking with electronic health record data and, if possible, claims data as well. One of the great costs in a PBRN is collecting the data, finding the patients. Electronic health records have made that a lot easier. And, for instance, identifying people with certain conditions can be done through electronic health records, and then the clinicians can recruit those patients. So I think that's an important element of a 21st century PBRN, because that's where the data are right now, and it's a shame to waste them if they're available.
Yeah.
So I guess we are. I just wanted to share that I guess we have this expertise to do research with electronic health records and to use electronic health records for our projects, and we also have access to claims now. So I think we have that. That's great to hear, because at least we have something that we can use to develop, to show or to develop PBRN.
Yeah, and I think something to think about is, I think that's again, this is thanks to the infrastructure that's been developed through the Delaware CTR. I think, in terms of identifying practices that would be part of the PBRN is ensuring, and obviously in the 21st century, more and more practices are using electronic health records, thankfully. But I think, as Dr. Wasserman noted, it's, also be able to link that data. So I think we are primed through the Delaware CTR because of that linking structure and the work that you, Claudine, have done in the BIRD and the CTR overall. I think we're in a pretty good position to begin to do that. It's exciting.
Any other question for Kim?
Oh, sorry, I did see in the chat. I wanted to see if there's any questions. Okay.
Well, I have another question.
Yes, please.
So in your review of the literature and your experience, did you find that the research questions were coming from the physicians or the patients from the PBRN, or more in relation to researchers who are associated with the practices? So is it more, growing from the internal practice with question that grows directly from the practice, or is it brought by, an external researcher?
Yeah, I'm really glad you asked that question, because it's the point I definitely was trying to, again, hammer home, is that I believe the spirit of the PBRN is that these questions, as I refer to, like practice relevant research questions. So the essence of them is that they should be originating from the practices themselves, from the clinicians who are full-time primary care, seeing patients every day, and seeing, identifying issues that of opportunities of where they would want to improve care. But I think it also comes from a partnership with the researchers. Again, like what we do in iReach at Christiana Care, formerly the Value Institute, working with clinicians side by side, talking through the concerns and opportunities they're observing, and together developing the research question. So, the topic, the concern is coming from the practice, but then together partnering to develop, what's the best question to address that issue. And then some PBRN projects also then have some patient advisory input as well, which I think can be really essential for most projects. I think there's a lot of similarities, and I think the spirit and principles of community-based participatory research is really, I think, it's seen in many of the successes of PBRN projects. So I think utilizing those principles, even incorporating those principles actively in PBRN project studies would be really beneficial.
Kim, I asked this in the chat, but what's your sense of how long it takes to establish a PBRN? So, relationships take time, community work takes time. Like, is it an endeavor, like a 5 to 10 year endeavor? Is it like a 1 to 2 year endeavor? What's your sense from what we've seen?
That is a great question, and it's something I am honestly not sure about. And that's all with Claudine's question. I'll do another deeper dive on that to see if I could see any timelines. Because I think especially some of the earlier PBRNs are really good about documenting their development. And I think it depends on probably on a few factors. I think it depends on what existing infrastructure you have. So like if you are working with an existing CTR or a CTSA, I think what's so exciting about that partnership is that you have that existing infrastructure to start with. But if you are, a research, like a family medicine department at an academic health system, and you want to identify practice-based networks and you're kind of starting from scratch, I think it could probably take a lot longer. But in terms of actual timeline of what that means, that I wouldn't feel prepared to really answer yet. But I'm guessing, it's not something that's going to be done in 6 months, as many would probably agree with me on that. But yeah, and I think it goes back to when you're developing an infrastructure, like the resources I reviewed talked about developing, vision, mission statement, but also strategic plan. Most strategic plans are written in like terms of 3 to 5 years. So I think, maybe the first year or two is just kind of getting things up and running, getting those commitments. And I think the same as this talk, the work in like community-based participatory research, these are not processes that happen quickly. It's not just about, I guess, establishing an administrative and financial infrastructure, but I think also creating that sense of trust and that true partnership. That also takes time and not something that necessarily should be rushed. But I think there could be, exciting milestones you could set in the short term. But then maybe midterm, long term is when you kind of start getting the studies up and running. But I'll definitely take a deeper dive on that to get some more specifics. Thank you.
I just have a quick question. You had mentioned that this is all about linking practice with clinicians to researchers. In your review or in your experience, have there been studies that kind of look at how the clinicians themselves have contributed and whether they're satisfied with their contribution, whether they have time to contribute, that kind of from that angle?
I did not see that, but thank you for that question because that's something I personally am interested in. So another key element of dissemination implementation research and a key differentiating factor between that and maybe clinical effectiveness research is you're starting with evidence-based practice, but you're also focusing on the professional, the person who's delivering that evidence-based practice. So a lot of that research, that focus of translating evidence into practice, you're focusing on the people who are actually doing the translating. And in our case, it is primary care providers. And so it's focusing on, outcomes and implementation research have to do with adoption and acceptance, in addition to like fidelity to that evidence-based model. So really exploring their experiences with it. So I think there are a number of opportunities, and I think it's essential to actually ask those questions and do that exploration and do it in a systematic and rigorous way, because I think that's, and I might be biased, but I think that is, one of the best ways and what we've identified as kind of part of that continuum of clinical and translational research of translating evidence-based findings into practice is utilizing strategies focused on, in our case, providers and their experience of translating those evidence-based findings into practice. But I will look for some study examples to see if other PBRNs have done such exploration, because I think that could be a really helpful model to follow.
Last question for Kim.
Well, if no one has any other questions, I just wanted to say thank you for this opportunity. I hope you found this to be instructive. I really appreciated all your questions and your feedback. This is all going to go into a report I'm going to go into that has some more details, and I'd be happy to share my slides and that report with anyone who is interested. So thank you for your time today. I really appreciated it.
Thank you, Kim.
Thank you.
Thank you.
Bye.
Thanks, everyone.
Thank you.